We'll start. All right. So we have our one and only Dr. Kweki with us. Very interesting. And today we'll be taking a presentation from Dr. Anita Namon on cyanotic congenital heart disease. Please let's give our keen attention. After 45 minutes, we'll have cerebral interaction. Meanwhile, we welcome the class reps, Dr. Florence and Dr. Sori Conte. So Dr. Anita, you have the floor. And afterward, Dr. Florence, you can coordinate. Thank you so much.
Thank you. Thank you very much. Thank you, everyone. Good evening, my teachers, chiefs, esteemed colleagues. Today I'll be taking, I have attempted to summarize a very vast topic, cyanotic congenital heart disease today, and I will be discussing it according to this outline, and I look forward to the interactions. If there's any further information you need me to add, I'll be happy to source that for you, and we can learn together. Right, so congenital heart disease refers to structural abnormalities in fetal development involving the heart and or intrathoracic great vessels. It can be non-cyanotic or cyanotic, as we know. It is the most common type of birth defect. And with cyanotic congenital heart disease simply refers to these structural abnormalities that result in...
So sorry, Dr. Please, your slide, I don't know if it's only on my side. Your slide is not...
you cannot see?
Yeah, it's splitted. Can you...
It's what?
The slide, the interface is splitted. Like, we are seeing two slides and none of them is clear.
Oh, okay, sorry.
All right, yeah, slide share
now. Is it
now.
better now? Is it better now?
No, it's not. It's not. So just go to slide share at the bottom right of your screen. And screen view, yeah. And click on it. Yeah. No? On the laptop.
I think it's in the upper part of the screen, the upper left. The
okay,
slide,
upper left.
Yeah, the slideshow icon is there.
Okay.
Upper left.
Slideshow. Okay, that's actually what I was using. So you are seeing two screens. Was that the problem?
No,
yeah,
no, Chief, I think you're right. I think you're right. It's down here. Down.
Right. So let's. Okay. Right. So cyanosis is perceptible in newborns when there's deoxygenated hemoglobin levels in the capillary bed that exceeds 3 grams per liter. So cyanotic congenital heart disease has also been described as critical congenital heart disease. We'll see why later. Lots of bodies that we follow that have released guidelines have classified cyanotic congenital heart disease as complex diseases or severe diseases, and that's significant in their management. So they've been classified as right heart obstructive lesions, left heart obstructive lesions, and mixing lesions. So the right heart obstructive lesions, we'll just list them briefly, include pulmonary atresia with an intact interventricular septum, tricuspid atresia, tetralogy of Fallot, critical pulmonary stenosis, severe neonatal Epstein anomaly. Left heart obstructive lesions include the hypoplastic left heart syndrome, interrupted aortic arch, which is an extreme form of coarctation of the aorta, where there's a complete interruption between the left common carotid artery and left subclavian artery. I'll show you pictures of these later on. And this is usually associated with a large non-restrictive ventricular septal defect. Now, basically, they're called left heart obstructive lesions because the systemic circulation is obstructed, and therefore there's a lot of shunting, which produces cyanosis, as we'll see later on. Next one is coarctation of the aorta, which is a discrete narrowing of the aorta. It could be various locations. It could be a preductal location. It could also be a postductal location where you find the narrowing of the aorta. Critical aortic stenosis is one of the left heart obstructive lesions, and it is the most common LVOT obstructive lesion. It could be fatal if it is left unattended, and it produces cyanosis as the ductus arteriosus closes in early neonatal life. Mixing lesions are a bit more obvious and easier to understand. So there's three of them: transposition of the great arteries or great vessels, and there's total anomalous pulmonary venous return, where the pulmonary veins drain into the systemic circulation instead of the right atrium. And then there's truncus arteriosus, which is simply a single great vessel. So it involves mixing of the pulmonary and systemic circulations and with resultant cyanosis. A brief look at the etiology. It's largely unknown. Lots of hypotheses abound, but it could be a combination of genetic and environmental factors. A lot of chromosomal abnormalities in 15 to 20% of cases have been implicated. Down syndrome, trisomy 21, trisomy 13, trisomy 18, Turner syndrome, Alagille syndrome, Di-George syndrome, that's the 22q11 deletion syndromes, Klippel-Feil have been implicated in tetralogy of Fallot, most especially, though quite quite paradoxically, the non-syndromic patients present the vast majority in TOF in terms of etiology. Environmental factors include maternal diabetes, maternal metabolic diseases such as phenylketonuria, toxin exposure, viral infections. So a host of things can give rise to congenital cardiac cyanotic congenital heart disease. In terms of epidemiology, it's about 8 to 9 per 1,000 live births. And cyanotic congenital heart diseases form 1/4 of congenital heart diseases in total. There is a higher incidence in the second pregnancy if the first sibling is affected or if a parent is affected. So this comes to play in genetic counseling when these couples come to meet us in clinic and they've had a sibling and they ask what is the likelihood that our next child will have this disease. Tetralogy of Fallot is the commonest cyanotic congenital. It is the commonest congenital heart disease, 7 to 10% out of all congenital heart diseases. Incidence of 4 per 10,000 live births. Transposition of great arteries is the next most common, and this is most likely to manifest in the first week after birth in about 2% of cases. So understanding the pathophysiology of cyanotic congenital heart diseases is not really possible without discussing fetal circulation. So this is a diagram that will help to remind us, hopefully, of, excuse me, of fetal circulation. So basically, the fetus receives oxygenated blood through the umbilical vein from the placenta. And then this is the ductus arteriosus. It drains into the inferior. Hello, can you hear me? Hello? Okay, I'll just continue. Oxygenated blood drains through the umbilical vein to the fetus through the inferior vena cava and then crosses over through the foramen ovale or oval foramen into the systemic side or the left side of the heart. From there, it goes through the aorta and then goes down to the rest of the body. Now, just to note, if you can take a look at the picture, in the inferior vena cava, you have oxygenated blood. As it crosses over through the left ventricle into the aorta, it is joined by blood from the ductus arteriosus. Now, some blood from the inferior vena cava does go into the right ventricle, which then moves into the pulmonary artery. So this blood, because it's also mixed with it's also received blood from the right atrium, which has drained blood from the superior vena cava and the rest of the body, forming the venous return, is less oxygenated than the blood in the aorta. So if you notice, the blood is bright red in the arch of the aorta, but after the left subclavian artery, you can see the blood gets darker after it's been joined by the ductus arteriosus, suggesting that the blood here is less oxygenated than what it was before it joined before the ductus arteriosus gave its supply. This becomes significant when we are discussing ductal dependent lesions for cyanotic congenital heart disease. Because the lungs are not functional in fetal circulation, blood is diverted, so it doesn't enter the lungs. So any blood that goes to the lungs is just sent back and then joins the left atrium and then to the left ventricle before going to the rest of the body. So this is just a brief summary of what the fetal circulation should look like, the normal fetal circulation. Now, when this, after birth, post-parturition, we can see that the ductus venosus closes and then it forms the ligamentum teres hepatis. And then the inferior vena cava is no longer responsible for oxygenated blood or systemic circulation. The foramen ovale should close. The ductus arteriosus should close, forming the ligamentum arteriosum. Therefore, there should be no connection, thereby sealing off connection basically between the right and the left side of the heart and preserving both the pulmonary and systemic circulations without pathological shunting, thereby preventing cyanosis and circulation of deoxygenated blood where there should be oxygenated blood. Also, because the lungs are now functional, we can see that deoxygenated blood moves to the lungs and then comes back to the left atrium and then continues from there, because the lungs are now where blood gets oxygenated as opposed to the placenta in fetal circulation. So we can refer to this as frequently as we would like. So with closure of the ductus arteriosus and foramen ovale after birth, in patients with cyanotic congenital heart disease, symptoms can develop depending on what pathology we are discussing. Cyanosis may be caused by persistence of the fetal circulation, right to left shunting across the foramen ovale and the ductus arteriosus in the presence of pulmonary outflow tract obstruction, or in cases where there is persistent pulmonary hypertension of the newborn. Now, for right heart obstructive lesions, just to summarize what the pathophysiology is, because there is decreased flow to the lungs, okay, there's an obstruction in the right heart, in the right heart outflow tract. There is decreased pulmonary flow. Therefore, the PDA, or the ductus arteriosus, when present, shunts blood from the aorta to the pulmonary artery, and this causes a right to left intracardiac shunt. The foramen ovale is persistent and it shunts deoxygenated blood from the right atrium to the left atrium. And then the ventricular septal defect, if it is present, as it is in tetralogy of Fallot, then shunts blood from the right ventricle to the left ventricle. So in summary, you have a right to left intracardiac shunt because the outflow tract of the right heart is obstructed. So there's raised pressure, and therefore there is a likelihood to shunt blood from the right into the left, causing cyanosis. So in tetralogy, in the TOF, which is the commonest cyanotic congenital heart disease, there are 4 components: right ventricular hypertrophy, ventricular septal defect, an overriding aorta, right ventricular outflow tract obstruction, which could be from pulmonary stenosis or atresia. The pathophysiology depends on the degree of right ventricular outflow tract obstruction. The severity of right ventricular outflow tract obstruction determines the timing of onset, how early they present with cyanosis. The direction of blood flow across the ventricular septal defect is determined by resistance of flow into the systemic and pulmonary circulations. And severe right ventricular outflow tract obstruction results in early hypoxemia for the reasons we have explained, because there's raised pressure. So this is a picture showing us the tetralogy of Fallot. So you have the overriding aorta above a non-restrictive ventricular septal defect. Okay, so the septum should go all this way here, and the aorta should not override both the right and the left. Sorry about that. Should not override both the right ventricle and the left ventricle. So there's an overriding aorta, and we can see this is meant to be the right ventricular outflow tract. We can see a stenotic pulmonary valve. So therefore, there's high pressure here, and this forces blood into the overriding aorta, deoxygenated blood, causing a right to left shunt. And because there's raised pressure here from the right ventricular outflow tract obstruction, we have right ventricular hypertrophy, thickened muscle here. So that is just an attempt to explain the pathophysiology. Now, a look at more right ventricular outflow right heart obstructive lesion. So this is pulmonary atresia. So basically the valve is underdeveloped, is atretic. So it cannot open or function properly. And so there's a raised pressure within the right ventricular outflow tract. Blood cannot go through properly, and therefore it is forced through the patent foramen ovale, causing mixing of the valve of deoxygenated and non-deoxygenated blood. We can see that here the right ventricle is also hypoplastic. In tricuspid atresia, the issue here is that the tricuspid valve is atretic. So there is a loss of connection between the right atrium and the left ventricle. Sorry, between the right atrium and the right ventricle. So therefore, it counts as a univentricular heart, as a functionally univentricular heart. So because of that, blood is then forced from the through the patent foramen ovale into the systemic circulation. In critical pulmonary stenosis, it's the same pathophysiology as right ventricular outflow tract obstruction. So in this particular case, neonates are dependent on on a patent ductus arteriosus for adequate pulmonary blood flow. Otherwise, the lungs will not get much blood. So this cannot close. Otherwise, they become quite symptomatic. In Epstein's anomaly, on the left, you can see a normal heart, normal right ventricle, normal right atrium, normal tricuspid valve. On the right, however, you can see there is atrialization of the ventricle, because the tricuspid valve is not, it forms quite, it's placed quite apically. So it's the positioning of the tricuspid valve is much more distal, much more caudal than it normally would be, therefore causing a very large right atrium and undeveloped right ventricle with a displaced tricuspid valve, therefore forcing blood through the atrial septal defect or a PFO into the systemic circulation. So this is basically what we have explained. So it is significant because it is most frequently associated with the risk of arrhythmias and sudden cardiac death. There are accessory pathways associated with this particular anomaly that give rise to arrhythmias later in life. And these patients can present with atrial tachycardias or atrial fibrillation. Left heart obstructive lesions produce a decreased systemic flow. So therefore, the patent ductus arteriosus supplies systemic blood flow by shunting blood from the pulmonary artery to the aorta. And there is a left to right intracardiac shunt with secondary pulmonary overcirculation. So basically, they have pulmonary hyperemia. And the patent foramen ovale shunts oxygenated blood from the left atrium to the right atrium. And when the ventricular septal defect is present, blood is shunted from the left ventricle to the right ventricle. This is a picture of the hypoplastic left heart syndrome. So we can see that there's basically no left ventricle here. So normal heart on the left, hypoplastic left heart syndrome on the right, and it's frequently associated with mitral atresia. Here, the mitral valve is underdeveloped. So basically, they have no left heart. They have no systemic circulation. So only one functioning ventricle. They do fall under those that are said to have a univentricular heart. So this then means that they are prone to cyanosis because most of what is circulating is deoxygenated blood. Coarctation of the aorta, as we earlier mentioned, is just a schematic presentation of the different levels where one can have coarctation. They basically present with differential pulses, So weaker pulses in the distal extremities, and they can also have differential oxygen saturation, differential cyanosis. In mixing lesions, there is mixed pulmonary and systemic blood flow, which leads to cyanosis. And these are considered ductal independent lesions. They do not require a ductus arteriosus in their pathophysiology, and they can present with or without patent foramen ovale. They include transposition of the great arteries, whereby the pulmonary artery, instead of arising from the right ventricle, arises from the left ventricle, and the aorta, instead of arising from the left ventricle, arises from the right ventricle, as this picture shows. So it can be simple or complex. So TGA is called simple in the absence of associated congenital anomalies, and it is called complex in the presence of associated anomalies, such as ventricular septal defect, left ventricular outflow tract obstruction, and coarctation of the aorta. And this basically affects how the patients respond and their survival following surgery. So long-term outcome of complex TGA is worse than that of simple transposition of the great arteries. Truncosarteriosus, single large vessel, single great vessel, the aorta and the pulmonary artery are fused, and we can see the potential for cyanosis here because there's usually a large non-restrictive ventricular septal defect associated with this. Lots of opportunities for shunting and mixing of oxygenated and non-oxygenated blood. Now, the total anomalous pulmonary drainage basically is a situation whereby instead of the pulmonary veins draining into the right atrium, they drain into the systemic circulation. So there is lots of potential for mixing of oxygenated blood with deoxygenated blood and then moving back to the systemic circulation. So just to summarize, the ductal dependent lesions, those that require ductus arteriosus, patent ductus arteriosus, hypoplastic left heart syndrome, critical aortic stenosis, critical coarctation of the aorta, interrupted aortic arch, tetralogy of Fallot with pulmonary atresia, pulmonary atresia with intact ventricular septum, critical pulmonary stenosis, tricuspid atresia, severe neonatal Epstein's anomaly, and transposition of the great arteries. This is just a slide to help us summarize the pathophysiologies of the cyanotic congenital heart diseases. Hopefully, will be useful. And just to mention the univentricular heart. So it's a syndrome basically where you have a functionally single ventricle. It includes conditions such as a double inlet right ventricle, double inlet left ventricle, hypoplastic left heart syndrome, right heart syndrome, single ventricle with undefined morphology, tricuspid atresia. So basically, these patients have a functionally single ventricle. And that's significant for consideration of repair, as we will see later on. So clinical presentation. Basically, the symptoms, they tend to present early in life because it's a congenital heart disease. So you have an infant that's irritable, or they're either hyperagitated or they have a decreased level of activity, but these children just do not behave normally. There could be excessive sweating, crying with feeds because they cannot stop breathing because of their poor levels of oxygen. They cannot stop respiration enough to sustain feeds. There's a decreased amount of formula per feed. They don't eat very well because you need to suspend respiration to swallow basically, and it's not possible when one is deoxygenated. History of longer time per breastfeed, poor weight gain, failure to thrive. They are persistently tachypnic. They could have abnormal breathing patterns, bluish or purple discoloration of the skin or mucous membranes, which is basically the cyanosis. Exercise intolerance, if they persist to early childhood with dyspnea, diaphoresis, cyanosis, or palpitations during exercise. And then there's the classic sign where a child is playing and then he feels deoxygenated and then he squats down. This is basically to increase venous return and thereby force blood back into the systemic circulation when they become dyspneic. In terms of signs, they present with cyanosis, which is the hallmark feature of these diseases. Cyanosis could be differential or it could be reversed. Differential cyanosis occurs when there is a right to left shunting across the ductus arteriosus, resulting in a lower oxygen saturation level in the lower body, such as in critical coarctation of the aorta, an interrupted aortic arch, or critical aortic stenosis. Reverse differential cyanosis, this is rare. It's usually associated with either coarctation or it usually occurs in transposition of the great arteries associated with either coarctation of the aorta or pulmonary hypertension. In this sort of presentation, the oxygen saturation is higher in the lower extremities because the most oxygenated blood is pumped by the left ventricle. Just to make mention of hypercyanotic or TET spells. So TET is just short form for tetralogy of Fallot, where the patients or infants are quite upset, agitated, and then they become they can become quite irritable, they are quite inconsolable, there's profound cyanosis, they turn quite blue, and if left unattended, they could have loss of consciousness and subsequent cardiac arrest. This is significant in management. So for example, when you want to palliate an infant for surgery, an infant is, for example, premature and not fit for surgery. The surgeons don't want to operate because of high risk. These are some of the features that we consider as high risk when referring these patients for surgery. So if they have frequent hypercyanotic spells, or if they have recalcitrant, refractory hypercyanotic TET spells, it is an indication for surgery or palliation with shunts. There's an increased work of breathing, pulmonary edema, tachycardia, heart murmurs, hepatomegaly, defined as liver edge located more than 2.5 cm below the right costal margin, weak femoral pulses. They could present in shock, and there are features suggestive of lethargy. Evaluation, of course, entails a detailed history and examination. You need to take obstetric history. You need to find out what is the family history of this patient. What was the mother exposed to? So obstetric history, family history, genetic history, detailed history and examination. Then one of the cardinal screening methods that we use is pulse oximetry screening. And the advice is not to do this before 24 hours postpartum. You can do it on either the right hand or either foot. Now, it is positive when there is any oxygen saturation less than 90%, when there's oxygen saturation less than 95% in both extremities on 3 measures, each separated by 1 hour, or when there is more than 3% absolute difference in 3 to 5% absolute difference in oxygen saturation between the right hand and foot on 3 measures, each separated by 1 hour. It could also be differential cyanosis, as explained. For example, when an infant has persistent pulmonary hypertension of the newborn with an interrupted aortic arch or coarctation of the aorta, lower oxygen saturation in the lower extremities. Why is that? That warrants further evaluation. Reverse cyanosis. So you can't just check on one limb. So you do on upper and lower extremities, especially when you are suspecting that this patient has a congenital heart disease. If pulse oximetry is positive, you move to a 4-limb blood pressure measurement. Check blood pressure in all 4 limbs, and then you move on to chest X-ray. It's simple, it's accessible, and it can show a number of signs, pictures of which I'll show you in a minute. The egg-shaped heart seen in transposition of the great artery, snowman in total anomalous pulmonary venous return, boot-shaped heart in TOF, extreme cardiomegaly in Epstein's anomaly. ECG basically can show rhythm abnormalities, can show atrial or ventricular hypertrophy depending on the pathology, dextrocardia, abnormal axis deviation. Echo remains a definitive non-invasive screening test and diagnostic test. It can determine the degree and direction of the shunt and the gradient of outflow tract obstruction. Okay, so these are just a few pictures to show the egg-shaped heart over here on the left, top left, and then top right we can see. So this is the snowman heart for total anomalous pulmonary venous drainage. So basically these are the anomalous pulmonary veins which form the hands of the snowman. And then for TOF, of course, there is the classic boot-shaped heart, which basically represents right ventricular hypertrophy. And it's just an ECG showing dextrocardia. One would think that the leads were displaced, but this is basically what it looks like. Now, there are 7 primary cyanotic congenital heart disease screening targets: hypoplastic left heart syndrome, pulmonary atresia, TOF, total anomalous pulmonary venous return, transposition of great arteries, tricuspid atresia, and thrombosarteriosis. Secondary screening targets coarctation of the aorta, interrupted aortic arch, because these produce differential cyanosis, critical aortic stenosis, double outlet right ventricle, Epstein anomaly, and single ventricular complex or univentricular heart. Not all of these cyanotic diseases are picked up during screening. As much as 15% can be missed. And out of these, the most common are total anomalous pulmonary venous return, TOF, and coarctation of the aorta. As part of evaluation, we also consider the hyperoxia test. So this basically means doing an ABG, arterial blood gas at room air, and again in 100% inspired oxygen after 10 minutes. In neonates with congenital heart disease, they are not able to increase oxygen saturation above 100 millimeters of mercury during 100% oxygen administration. They can't go above 100 with 100. However, in those who have lung parenchymal disease, it's a differential. They can also present with cyanosis. They can increase their oxygen saturation if you increase the percentage of inspired oxygen. So this is because they overcome their ventilation perfusion discrepancies, basically. So this is one way that you can use to differentiate with the hyperoxia test. For one can consider more advanced imaging, especially when sending these or working up these patients for surgery, inclusive of left and right heart cath, magnetic resonance imaging, CT scanning to further visualize cardiac anatomy. So this is more of advanced imaging. The specific screening features. Now for right heart obstructive lesions, they have positive screening with oxygen saturation. So positive pulse oximetry screening with oxygen saturation less than 90%. They usually do not have differential cyanosis. The hyperoxia test is positive, meaning that they cannot oxygenate more than 100. Chest X-ray will show the features that we have described depending on what it is, and it could show either decreased or normal pulmonary blood flow. ECGs, there's axis deviations. Pulmonary atresia, left axis deviation, tricuspid atresia, left superior axis, and right axis deviation for TOF. For left heart obstructive lesions, they have positive screening with oxygen saturation of less than 95%, but greater than 3% difference between upper and lower extremity oxygen saturation. So that they have differential cyanosis. They have negative hyperoxia tests. They have positive blood pressure gradient between upper and lower extremities, except for hypoplastic left heart syndrome, because they basically cannot generate much blood pressure. Chest X-ray shows increase in pulmonary blood flow because most of the blood is shunted there and they have excess pulmonary blood flow. ECG would show normal axis for a newborn between 90 to 180 degrees, except for critical aortic stenosis, which has left axis deviation for a newborn 0 to 90 degrees. For mixing lesions, they do have positive oxygen sat screening with oxygen saturation less than 95%. They usually do not have differential cyanosis because the mixing occurs in a more central location. Apart from transposition of the great arteries with pulmonary hypertension or coarctation of the aorta where the oxygen saturation is higher in the foot than in the right arm. They have a negative hyperoxia test. And chest X-ray can show normal to increased pulmonary blood flow. ECG would show normal axis for a newborn 90 to 180 degrees. Treatment. We need to emphasize that it is a multidisciplinary / interprofessional approach involving the neonatologist, the pediatrician, the geneticist in many cases, the cardiologist, the cardiac surgeon, and ICU needs to be involved and informed, as well as of course our excellent NICU nursing staff. When these diseases are diagnosed prenatally, plans have to be made for specialized delivery attendance or specialized delivery service, preferably in a tertiary center where there is access to surgical facilities. However, when it is diagnosed after birth, they should be supported with oxygen as needed, other supportive measures. Prostaglandin E1 infusion is used to keep the ductus arteriosus patent as bridging therapy to surgery whilst you're trying to get the child across or walk the child up for surgery or get them across to a surgical center. They should be transported immediately to as soon as possible to a surgical center, which is required in 1/4 of cases, especially if they are very cyanotic. Surgical repair is usually timed in the first year of life, before 6 months if elective. And the general goal is to relieve right ventricular outflow tract obstruction. This is usually for TOF, which is the commonest. So we're focusing more on the common ones. So the goal for this is to relieve right ventricular outflow tract obstruction, to separate pulmonary and systemic circulations in situations where a patient has a univentricular physiology, to preserve right ventricular function, and to minimize post-procedural pulmonary valvular incompetence because they do present with pulmonary regurgitation later on in life, which is how they end up in our clinics as adult cardiologists. Palliative shunts, right ventricular outflow tract stents, or ductal stents can be used as a bridge to repair in preterm infants, so they are too small for surgery, or in those with unfavorable coronary anatomy, especially in refractory TED spells or hypercyanotic spells, or those with severe right ventricular outflow tract obstruction. So specifically in transposition of the great arteries, the operation is called an atrial switch. This has transitioned over time to an arterial switch procedure. Complex transposition of the great arteries are operated on using a Rastelli type repair. So the Rastelli type repair, I'll just show you a picture soon, but it's a surgical repair for children born with this disease, and basically it involves redirection of ventricular outflow with an intracardiac baffle, which tunnels the left ventricle to the aorta, and external valve conduit, which connects the right ventricle and the pulmonary artery. So basically correcting what was fused, separating the systemic and pulmonary circulations. Hopefully this picture is clear enough. So we can see this is a patient with truncus arteriosus, pre-Rastelli procedure, and post-Rastelli procedure. This is the baffle that has been used to create a proper connection between the right ventricle and the pulmonary artery. This is significant because in adulthood they can present with baffle stenosis. So this can narrow later in life, and then they present with right ventricular outflow tract obstruction and features associated with that. So we need to be careful. Balloon atrial septostomy is a palliative procedure that can be performed acutely in transposition of the great arteries to encourage adequate blood mixing. So basically, this is just a picture that shows it's a catheter-guided procedure. So you basically you puncture the septum. Okay, you puncture the septum, inflate the balloon, and then take the catheter out to achieve that connection. The goals of repair in tetralogy of Fallot is relief of the right ventricular outflow tract obstruction, as previously mentioned, and this usually involves infundibulotomy, resection of the obstructive muscle bundles, and the use of a patch to enlarge the pathway from the right ventricle to the pulmonary arteries. For the univentricular heart, what is done is the Fontan-Krautzer operation, or the Fontan procedure. So this is just a picture showing the Fontan procedure. So the top left, we can see a normal heart, and on the top right we can see hypoplastic left heart syndrome. So basically, this is the left ventricle; it's barely there, and then you want to do a Fontan procedure. So basically what that does is that it connects, it basically directs venous blood where it should go. So it connects blood from the IVC to the pulmonary arteries so that venous blood ends up in the lungs and there isn't much opportunities for mixing and cyanosis. Post-op complications, acute post-op complications include respiratory failure, cardiac rhythm disorders, heart failure, renal failure, seizures, thromboembolism and stroke, hemolysis, infections. Then there's this post-pericardiotomy syndrome, which is an inflammatory response of fever, pericardial fiction, rub, pleuritic chest pain, new or worsening pleural effusion. So basically a reactive serositis. So if at least two of these are present, it is diagnostic of post-pericardiotomy syndrome. It can present days to weeks post-surgery, and it results from increased immune response to injury following cardiothoracic surgery. So these are some of the post-surgical complications that we need to watch out for. So these patients should be adequately supported in high dependency units and complications managed as they arise. For post-op management / supportive care, peri-op supportive care, there's been a lot of discussions about routine immunizations and vaccinations when they should be given. So I've checked a lot of guidelines and there's no clear consensus. However, they do agree that we should consider the timing of administration of live virus vaccinations because the presence of congenital heart disease does reduce their immunity. But what we should remember is that recent vaccination is not a contraindication to surgery. So try not to delay surgery just because the patient has had recent vaccination. There is a question of whether patients that are connected to the heart-lung machine for cardiac surgery, with attendant blood transfusions and immunologic issues, might need to be revaccinated. So there's an economic implication there. However, it is not a contraindication that the patient has had recent vaccinations to delay their surgery. What they do recommend is that vaccines should be given, and where it is possible in elective surgeries, for inactive vaccines, you can wait up to 48 hours after. Prophylaxis against RSV is recommended in the respective season, for example, in winter season, in infants with unrepaired congenital heart disease and significant hemodynamic abnormalities. Bacterial endocarditis antibiotic prophylaxis is recommended for patients undergoing dental procedures or invasive airway procedures, airway support, tracheostomy, etc., and in unrepaired or palliated TOF. So endocarditis is a very serious complication that can occur, and the cyanotic congenital heart disease is considered high risk. So patients going for dental procedures should have antibiotic prophylaxis. Treatment of iron deficiency anemia when present, treatment of excessive polycythemia. They are prone to erythrocytosis because of cyanosis. So the body responds by producing more red blood cells. This leads to viscosity, hyperviscosity. They are prone to strokes. Therefore, they need proper hydration to prevent strokes. And then further down, genetic counseling regarding the probability of a cardiac malformation occurring in subsequent children. We also need to counsel them, those that make it to adulthood, on things such as pregnancy. We'll touch on that soon, just in case we run out of time. Things like pregnancy. If a patient makes it to adulthood and has pulmonary hypertension, you're advised against pregnancy. And they always ask they generally ask, how much exercise can I do? There's no evidence that strenuous exertion is beneficial in these groups of individuals. For differential diagnosis, pulmonary disease is a very close differential, ranging from atelectasis to pneumothorax, transient tachypnea of the newborn. Any one of these can present with cyanosis, including pneumonia. Metabolic disorders, severe hypoglycemia. Yes, they can present with cyanosis, sepsis from any cause, polycythemia, airway obstruction, large airway obstruction. They could just have airway abnormalities and they are cyanosed.
Okay, Dr. Nita, you have like 10 more minutes more.
I know, I'm
5 to
trying to
10
rush. I'm so sorry. I'm so sorry.
Thank you.
Okay.
It's a very
We'll
fast
just
topic. Thank you.
prognosis. Okay. Yeah, just prognosis. About 75% of them are expected to survive to 1 year of age.
Dr. Inamanu, please, you don't need to be don't be under pressure. You can just take your time. Maybe because I'm sensing that you're under pressure. But just take your time. I know the topic is quite broad.
It's
And
very
please just take your time. I've spoken to the coordinator. Thank you.
no problem. You will have the slides anyway, and I'm happy to add whatever is needed.
All right,
So,
that's fine. All right.
yeah, prognosis. Yes, so children with cyanotic congenital heart disease are at an increased risk for developmental delay and disability, arrhythmias, heart failure, sudden cardiac arrest, or stroke. Adults with cyanotic congenital heart disease, this is significant because a higher percentage of individuals now survive into adulthood. As a result, we are seeing more of them in clinics. One thing to remember, or a few things to remember, is that care for patients with congenital heart disease is a lifelong thing. They require lifelong follow-up. There's never a time when you repair and you just discharge. They do require lifelong follow-up because complications can develop at any time. Now, there should be a careful transition between the childhood period and the adulthood period, from childhood into adolescence, into adulthood. And this should be a multidisciplinary approach, teams including specialist nurses, psychologists, because these are individuals that are actually living with this disease. Their lives are not normal per se, and they are people that will require lots of ongoing care, lots of ongoing procedures, lots of ongoing investigations throughout life. It can have a psychological effect on them. Just to mention that we are managing a holistic patient. So just a brief mention on I just highlighted this table because it was an academic discussion, sort of comparing the American guidelines and the ESC guidelines, or classification of complex congenital heart diseases. This just means that they require closer follow-up, and just to keep a closer eye on them in terms of follow-up. So on the left, you have the ACC-AHA classification of complex diseases. And then on the right, you have the ESC classification. So basically, the ESC uses mild, moderate, and severe. So for severe, any cyanotic congenital heart disease, unoperated or palliated, falls under severe congenital heart disease. So just wanted to highlight that. Anyone that has undergone a Fontan procedure, it falls under severe or complex complex congenital heart disease. In patients that have unrepaired cyanotic congenital heart disease, they do require infective endocarditis prophylaxis, good oral and cutaneous hygiene. We discourage things such as tattoos and ear piercings because they are prone to infections, just in case they are asked. High-risk conditions include prosthetic valves, including transcatheter valves, any cyanotic congenital heart disease, any congenital heart disease repaired with prosthetic material up to 6 months after the procedure, or lifelong if there's a residual shunt or valvular regurgitation remains. Management of complications, basically involving the different specialties, thromboembolic phenomena, they might need to be on anticoagulation. Gallstones, hyperuricemia might need to be managed in conjunction with surgeons. Neurologic complications, of course, neurologists. They are advised to stay hydrated, avoid volume depletion, only for anticoagulants if indicated, because cyanotic congenital heart diseases can present with both bleeding and hypercoagulability. So unless they've got a mechanical valve or a documented arrhythmia or some thromboembolic phenomena, usually anticoagulants are not advised. And there is a risk of sudden cardiac death, especially in TOF, incidence of 2% per decade. Okay, I'll just skip this bit. And this is just an area of confluence between what we should be focusing on in adults with congenital heart disease, sports eligibility, pregnancy and reproduction, and so on. This is just a slide showing pictorial representation of repair for TOF and the possible complications following repair. They can have pulmonary regurgitation, or right ventricular outflow tract obstruction. It can present with ventricular arrhythmia. Okay, and basically, if they've got severe pulmonary regurgitation, class 1C recommendation, they should go for surgery because they are at risk. It's just a snippet of the ESC guidelines for repair of coarctation or recoarctation in those with coarctation of the aorta when there's an increased non-invasive gradient between the upper and lower limbs confirmed with invasive measurements. And then for right ventricular outflow tract obstruction, if they've got severe stenosis and they are asymptomatic, class 1C. So they're all basically expert opinions. They don't really have much data, but they're class 1 because they are thought to be beneficial. And the Doppler peak gradient cutoff for right ventricular outflow tract obstruction recommended for surgery is greater than 64 millimeters of mercury, just to highlight that. For Epstein anomaly, surgical repair is recommended in patients with severe tricuspid regurgitation or objective deterioration in effort tolerance. Okay. And then for those who have survived the Fontan procedure, they present in adulthood. If they have atrial arrhythmia, it should be treated promptly, the electrical cardioversion, because we don't want them to enter malignant arrhythmias. Anticoagulation is indicated if there is an atrial thrombus or atrial arrhythmias or thromboembolic events, and they are counseled against pregnancy, usually. Class 1C indication, just to highlight that. In conclusion, cyanotic congenital heart diseases form a significant group of diseases with varied presentations and with considerable morbidity and mortality. They come with a broad spectrum of complications in both the repaired and unrepaired cases, and can present in childhood, or now we can see them moving on into adulthood. So we have increased contact with them. Management is lifelong and multidisciplinary in these cases. These are my references. Thank you very much for listening.
Okay, thank you. Thank you so much, Dr. Anita. You're actually in diaspora, but you still showed up. I did not really expect this from you, and you did a beautiful presentation. It was well delivered. Thank you so much. I really do appreciate. So it's time for questions and comments. So the floor is open. So we'll move in an ascending order. We would ask questions. Thereafter, chiefs are going to follow suit. Okay, so I don't know if we have questions or contributions to make as regards the topic cyanotic heart disease. Dr. Mohammed, do you have any question or contributions? Dr. Mohammed? Okay. Any questions from anyone or contributions?
Yes, hello.
Dr. Okay, thank you so much, Dr. Conte.
Yeah, just to start with, to appreciate Dr. Anyway, I'm not seeing the name anymore. Anyway, so thank you for very
Namoni, Anita, Namoni.
Thank you for a very,
Namono.
Doctor,
You can call me
Conte,
Anita, it's fine, please.
Yeah.
Dr. Conte, it's not easy for you from Sierra Leone to pronounce an Igbo name. So just pronounce the Anita. All right.
Thank you very much for a very comprehensive synopsis of cyanotic congenital heart disease. I just want to make a contribution to emphasize the need for multidisciplinary team management of these patients. Because like you mentioned, it's lifelong treatment. And usually between the ages of 12 to 18, that's where they get problems. Because if they have initially been managed by a pediatric cardiologist, when they get to above 12, pediatric cardiologists want to offload them. And then the adult cardiologists do not want to receive them until they are 18. So it can be a tough time for them. And so you need to really have that multidisciplinary team management and have an overlap within those years before they are transitioned to the adult cardiologist. So that is very, very important. My concern is about this Rastali procedure. You know, we are putting a conduit early in life. You know, it is obvious that the other cardiac structures are going to outgrow that conduit. Do they give specific time to revisit or replace or the conduits that they put?
Okay, that's a very good question. I can look up the answer to this and get back to you if that's okay, because I don't know. I actually don't know.
Okay.
Yeah. But it does make sense to, even though I do know that it is they use membranous structures, so technically they should have some elasticity, but as I mentioned, yeah, I think that is why a lot of them actually do present with baffle stenosis, so that narrowing as they grow, which is why they need follow-up with constant echoes. You need to check the gradient across and all of that, but they do use membranes. I can't I will look into it in detail, okay, and post it on the group if you're interested. Is that okay?
Absolutely.
Can we get Dr. Kweki's opinion? Dr. Kweki, what do you think about the Rastali, the transeptal structure, and growing through age? Do you have experience or from where you practice in the UK? Dr. Kweki, sir.
I wish I can. I'm in a bus, so I'm not supposed to. Hello? If you can hear me, I'm in a bus. Hello, can you hear me?
Yes, we can hear you.
I'm in a bus. I can't really talk much. I didn't even hear all the things you said. So the next couple of minutes, I would come down like 10 minutes from now. I know I heard my name. I know Anita was asking a question on Conte, but I didn't even hear the detail of the question.
Oh, okay.
Once I
Probably when you get that, but Dr. Conte was at. Yeah, Dr. Conte needed clarification on the Rastali procedure and with respect to the growth of other heart structure as the patient goes through the age. What do we do and how do we manage it? So perhaps Dr. Naman will check it up and give us updates.
I can't even hear everything. So when I come down, please.
All right. Okay. So anybody else that can make contribution to that, Alison, Temi Adeyanju, and Paul can just unmute and speak on it. But if not, then we can proceed. Yeah.
Okay. So thank you so much, Chief Okupi. So I don't know if Dr. Alison, Dr. Adeyanju, they have any more contributions or questions as regards our presentation. Okay, so going to the chat room, everyone is applauding you. Excellent presentation, wonderful presentation, lucid, great. So that shows you did a beautiful presentation today. So we really do appreciate. Thank you so much. Thank you. Okay, so move on to the next section, which is the MCQ.
Dr. Florence, Dr. Alison wanted to speak. She unmuted. Maybe we can give us the floor.
Okay, that's fine. Yeah. That's fine. Thank you so much.
All right. Dr. Alison.
Yes, thank you, Chief Okupi. Thanks so much. Good evening. Dr. Anita, thank you. Thanks for your presentation. I didn't hear the full of Dr. Conte's. I'm sorry, I stepped out and I came back. But for just some little things that I picked when you were presenting, it was a beautiful presentation. Thank you so much. It's just to note that, for exam purposes now,
yes,
we won't be in animations like this. We'll have either a raw echo pictures.
Okay.
So I think before you submit your slides, if you can just give us those defects and how the echo features will be like, instead of animations that you have, like everything's are normally now.
That's fine.
Yes, you show those, but in will not see these animations. You see echo pictures. That's what we work with. So though you can put them side by side, but please give us animations. Then give us echo and pictures and not animation.
Thank you. Noted.
All right. So if I may ask, for PFO, what's the normal shunt direction? And for PDA, what's the normal flow direction? Because when you were presenting for for PDA, you mentioned something like flow from right, that's the right ventricle, or the right side to the left. So I wouldn't know. Then for PFO, so I know you mentioned them during your present. No, I know you are dealing with cyanotic at this thing, but what's the normal flow in PFO? What's the normal shunt flow in PD?
First of all, they are not normal. These are not normal conditions. Well, thank you very much for your questions and your appreciation. Thank you for the contributions. I will put on the echo images, and thank you for your question. So for normal PDA and PFO should not exist in normal situations, but for cyanotic congenital heart diseases, when discussing the pathophysiology, the direction of flow depends on the type of lesion, the cause of defect. So because there is like for example, if there is a I understand what you're trying to say. So when there is a persistent foramen ovale in adult life, yeah, because there's usually higher flow on the left, in the left atrium, yeah, most likely there will be a left to right shunt. Is that what you're trying to say?
No, that's exactly what I'm trying to drive at. In a PFO, when you have a PF, like the defect is just like a we have a flap, that's a foramen ballet that is not that flap that is not tightly opposed. You understand? It's supposed to be that operates that tunnel that we see in a PFO. So the PFO flow, the shunt should be from right to left, despite the fact that the pressure on the left is more than the pressure on the right. So that's what I'm trying to say.
Yeah, so that's what happens in cyanotic congenital heart diseases. Because especially, for example, if there is a right ventricular outflow tract obstruction, so blood cannot flow through the right ventricular outflow tract. So because of that sort of pressure difference, blood is then forced. So they do have shunts from the right to the left at the atrial level. Is that, yeah?
I understand that. But what I'm trying to say is, except there is a reversal of shunts, the direction of flow in a PFO is a right to left shunt.
Yes.
Except reversal, the direction of flow in a PDA, you understand, supposed to be a right shunt.
Left to right.
Yes.
So yes, so PDA, there is higher flow in the aorta. There's higher pressure in the aorta. So I mean, technically, it should, all things being equal, if there is a PDA present, there should be flow from left, or the systemic system to the pulmonary system, left to right, which is why when there's an isolated PDA, they are not likely to be cyanosed. If that makes any sense. Yes. So when there is an isolated PDA in the absence of any other factors, that because there's higher pressure in the aorta, by default, they should not be cyanosed. However, when, like for example, in a hypoplastic left heart and they're not generating much pressure, that's why they have a hyperemic pulmonary circulation, because most of the blood coming from the pulmonary artery flows through the patent ductus arteriosus into the aorta and mixes with the systemic circulation. So it does depend on the pathology that is present.
Yeah, fine. You're saying the same thing. Well, maybe my point is not clear, but no problem. Thank you. I'm saying that because the normal physiology we should know. I'm saying that because of MCQs. So that's why. Yes.
Yeah. Okay.
Well, let's just add something, and then probably I'll call on Conte to explain the concept we once had. Dr. Naman, a very brilliant presentation, really. Thank you for responding within a short time. Thank you. Just the way Dr. Allison stated, for the exam, Prof, or let me not call names, but then our examiner would definitely put echo pictures, not
yes,
real life echo pictures. And also, if you remember when Dr. Kweki went for the exam, one of the congenital heart diseases that was actually presented, it was more clinical. So probably your presentation was more towards interventional and surgical. So ECG findings, murmurs, clinical presentation, some of these cyanotic congenital heart disease just presented. So probably when you're sending the slide, if you can add some stuff, the ECG findings, the clinical presentation, it will be better a little bit, so that those going for exams will look at it and be prepared.
It'll be very useful. Thank you very much. That's very helpful. Thank you.
All right. Then let me call on Conte to please explain the concept he once did. so that some persons here may get it. Conte, please, can you help us again on that explanation on the murmur of PDA with respect to the cardiac cycle, and also the reasons why we have different structural configuration with ASD and ESD at different points. Dr. Conte, I don't know if you're there.
Yes. Yeah. Okay, so the first one is the murmur of PDA.
Yeah, the murmur of PDA with respect to the different cardiac cycle.
Oh, okay. So with PDA, because you know the communication is between the aorta and the pulmonary artery. Okay. So, and we know that it's when you have significant pressure difference between two communicating chamber and you have a flow across, that is what produces the murmur. So you need to have that turbulent flow across to cause the murmur. So because in this setting, we are dealing with arterial pressure and venous pressure. So right through the cardiac cycle, there is always a significant difference in pressure, okay? So in the aorta, normal people, your diastolic pressure, if an adult, okay, diastolic pressure will come down to 80, okay? And that is still way higher than, you know, the pressure that you find in veins. So you expect the murmur to be continuous, okay? So, but however, because your systolic pressure is higher, so there is a systolic accentuation of the murmur of PDA, okay? So the systolic component is actually louder compared to the diastolic component of the murmur, even though it is a continuous murmur, right? And then also, when you begin to get equalization of pressure, okay, so if instance you're having a large PDA that has been there for a long time, and that was not repaired, and you begin to develop pulmonary hypertension, and then you are moving towards an Semenga transformation. Then what you lose first is the diastolic component of the murmur. So you can still just have the when you listen, you can still hear the aortic component, sorry, the systolic component of the murmur without the diastolic component of the murmur. And then when the pressures actually equalize, you don't have any significant difference in pressure, and then you don't get a murmur at all. Okay. And then later on, when you get complete Semenga, the flow actually reverses. Okay. Concerning the difference between the pathophysiology that you have in ASD and VSD. Okay, so we know they are both left to right shunt, okay, in cyanotic congenital heart disease. But however, with significant ASD, you tend to get dilatation of the right heart, the right ventricle, okay, whereas when you have a large VSD, you tend to get dilatation of the right ventricle, and usually they present early with dilatation of the left ventricle, and they present early with left ventricular failure when they have large VSD. So the main reason for the difference is that the diastolic overload is happening, is coming at with, how do I put it? The feeling, the extra blood that is being shunted, you know, across the defect is going to different chamber in diastole. So when you have an ASD, okay, blood is shunted to the right, okay, and that shunted blood fills the right ventricle in diastole. And when you have increased filling in diastole, that causes the ventricle to dilate, the right ventricle to dilate. Okay, so you have a right heart dilatation, and then you end up with the right heart filling. But when you have a VSD, the shunting occurs during systole, ventricular systole. And when that extra amount of blood comes to the right ventricle in systole, it is just directed to the pulmonary circulation. It does not dilate the right ventricle, okay? Because the extra load is not coming in diastole, Because when you increase load in diastole, that is what causes dilatation. Because in VSD, that load is coming in systole, it is just directed to the pulmonary circulation. And now it is returned back to the left side. So it is on the left side that you get increased diastolic filling of the left ventricle. And therefore, it is the left ventricle that will dilate. So that is why infants who present with large VSD, they present early with left ventricular failure, typical LV failure. And usually when they manage them in that early life, you manage them like you are managing heart failure. So they have to be put on digoxin, to help diurese them, before them. So basically, those are the things that we need to note. Thank you.
Thank you so much, Dr. Conte. Please, if you have further questions, you can put it in the chat box. Over to you, Dr. Florence, for the next phase of the discussion.
Okay, thank you so much, Chief Okopi and Dr. Conte, for that great addition to her presentation. So, Dr.
Sorry, one more thing I need to mention about tetralogy of Fallot. So you can explain tetralogy of Fallot by one lesion, one problem that happens in the development, okay? And that is a problem with the infundibular septum. So you have an anterior and superior displacement of the infundibular septum, and that explains everything that happens. Some of the old books say it is an anterior cephalad displacement of the infundibular septum. So when that septum is displaced anteriorly, we know that the pulmonary outflow tract is anterior and the left ventricular outflow tract is posterior. Okay, so when it is displaced anteriorly, it produces pulmonary stenosis. And the degree to which it is displaced anteriorly, that is what determines the severity of the disease, actually, to determine how early the patient presents with cyanosis. And then the superior displacement is what is responsible for the large VSD. So it pulls the infundibulum upwards, and it leaves that large VSD at the bottom. And because it is the infundibulum that is displaced up, then the aorta become overriding. So the aorta now is sitting at the middle there, the infundibulum pulled up, and then it's overriding, it's draining blood from both the left side and the right side. So now the stenosis, the pulmonary stenosis will result in the right ventricular hypertrophy, okay? And that's how you can explain with just one lesion everything that happens in tetralogy of Fallot. Thank you.
Thank you so much, Dr. Conte, for that brilliant contribution. So in the chat room, Dr. Adeyanju is asking for emphasis on grown-up congenital heart disease and transition to adulthood is very important. So emphasis on grown-up congenital heart disease and transition to adulthood is very important. Then thanks everyone for listening. So, okay, so that's, okay, so Dr. Anita is saying, thanks everyone for listening so patiently. I appreciate your feedback and we'll make the necessary changes and send across later. Thank you so much, Dr. Anita, once more again. So move over to the next section, which is the multi-choice questions. So over to you, Chief Cyril. Thank you so much. So I'll be posting the MCQs in the chat room. Thank you.